Good morning. If we could please take our seats, we'll start the program. I'm Mark Fendrick. I'm the director of the Center for Value-Based Insurance Design. I want to thank each and every one of you for taking time out of your busy schedules to join us for our summit today, the evolution of clinically nuanced payment reform and benefit design. The VBID Center is starting its 10th year. This is our 5th summit, and we are extraordinarily pleased to reconvene again. One of the main roles of the VBID Center is to bring multidisciplinary and multiple stakeholders in the healthcare field together to talk about how to change the healthcare discussion from how much we spend to how well we spend. And as the director, I just want to go through a couple of housekeeping announcements before we get into the fabulous program that you see in front of you on your agendas. I think as I look around, the first thing I want to say is the VBID swag, which is the water bottles. For those of you who did not come into the main thing, there are several available. It's part of our sustainable, non-plastic water bottle approach to keeping you well hydrated throughout the day. And feel free to pick up one of these at the information desk at any time. It's a fairly action-packed day. We have 4 panels looking at various interesting topics, but I know many of you will have an absolute dire need to check your email or play some online games. So we have free wireless available. Just look for the network Guest. You'll be able to log in any or all of your electronic devices. We have ample breaks between sessions because our evaluations of past events have said how much people have enjoyed the networking opportunities to meet people in various aspects of the healthcare transformation discussion. So we hope you'll interact with each other and please seek out our many students who work for the Center for Value-Based Insurance Design who are looking to get exposed to people in the real world in various types of positions. Importantly, the bathrooms are straight out the back of the lobby on either side, men on my left and women on the right. And there will be refreshments available throughout the day for those who need sustenance to get through the content. And for those of you who are carrying luggage or coats, we have a secure coat room if you want to drop your stuff off, if that's certainly an option. And as I believe, if not every one of you know, but most of you know, that Susan Lynn Osterly has been working hundreds, if not thousands of hours to make this event possible, and she will be in the lobby throughout the day to answer any questions or concerns you may have. So let's get started. The Value-Based Insurance Design Center has been trying to engage people like you since our inception in 2005. Dean Smith, Michael Chernow, and I have been talking about clinical nuance and changing benefit design since the last century. I love saying that. Very long time, Steve. And I'd like to use today as a transformation for us talking about the VBID idea, but actually change the discussion a little bit and focus to the implementation of value-based insurance design. And to remember, the mission statement of our center is to have every American to have the option, not to mandate it anyway, the option to enroll in VBID plan if they'd like to do so. And we've seen lots of interesting momentum regarding value-based insurance design, and we've seen some issues confronted in terms of the role of VBID in commercial plans, and primarily around health savings account qualified high-deductible health plans, which will be the first session, and the potential role for value-based insurance design in Medicare, and specifically Medicare Advantage, which will be the focus of our second session. As we've gone through these events over the years, many of you who've been here at previous ones, we've seen people say, Mark, enough about subsidizing high-value services. What about the potential use of clinical nuance payment reform and benefit design to discuss low-value services? And we will have a panel just after lunch on expanding the use of clinical nuance across the spectrum of entire clinical care, not just drugs, to all aspects of care, and the good stuff, the carrots, and the bad stuff, the sticks. And we have held the broadest and I think what may be the most informative panel to last, which is going to be a number of state experts who will be assembled to talk about the opportunities and challenges that the current environment allows us to really make significant changes from a volume-based system to a value-based system. So before I introduce our welcoming speaker, I just want to say that the most important we heard from you about prior VBID summits is that you wanted us to keep the speaker time shorter and the audience time longer. And we have responded to that, so I'm going to say the pressure is on all of you, given that we have ample audience participation for each of our panels, to think about the questions and ask them, because all of our speakers and panelists are amazingly engaging and are here basically to hear from you and listen to what's on your mind and respond to them. So with that, we are very fortunate to have Dr. Michael Johns, who is the Interim Executive Vice President for Medical Affairs, to provide some opening remarks. Dr. Johns, importantly, is a graduate of the University of Michigan Medical School. Prior to his return to Ann Arbor, Dr. Johns completed nearly 2 decades of remarkable accomplishment and service at Emory University, where he was professor of otorhinolaryngology, health policy, and most recently served as chancellor. He wanted to come back to enjoy some really good football, which you don't get at Emory, and lo and behold, he shows up this year. Sorry about that, Mike. Prior to moving to Emory in 1996, he was dean of the Johns Hopkins School of Medicine and vice president of the medical faculty at Johns Hopkins. And as many of us in the room who look at initiatives, particularly in academic centers, Michael is really well known for implementing a number of models there at Johns Hopkins that are now kind of natural things for all of us at academic health centers to do. In education, in research, and tech transfer, models he put in place are really admired. Mike was born in Detroit. He received his bachelor degree from Wayne State and graduated with distinction from the University of Michigan Medical School, where he also completed his internship and residency. And I could speak for the entire University of Michigan community in saying that we are thrilled that Mike has returned to Ann Arbor, and we at the VBID Center are particularly pleased and honored to have him formally welcome all of you to this year's summit. Dr. Johns.
Well, thank you, Mark. I appreciate that kind and very generous, overly generous introduction. First of all, I just want to congratulate Mark on his election to the Institute of Medicine. It's a great recognition. And a really wonderful recognition of his contributions and accomplishments over the years. So it's great to see you join the ranks of the Institute. Now, in fact, speaking of the Institute of Medicine, that's where I was sitting in the value and science base of which we argued about what the title of that roundtable should be. That roundtable at the Institute of Medicine, by the way, it was formerly called the Evidence-Based Medicine Roundtable, as hard as I tried to say, couldn't we call it evidence-based health? Well, that didn't go anywhere. We doctors are very protective about the word medicine for some reason. But I'm sitting there in one of the sessions, and up stands this professor from the University of Michigan and gives his presentation on value-based insurance design. I'm sitting there thinking, yeah, that's it, of course. Which I think I told him afterwards, yeah, we need more of that, you know. And I was really taken with the concept because it seemed to make sense. How do we, you know, really promote health, which is something that I think is really important. So coming here again and having the chance now to get to know Mark better and hear more about it, it's really, and being a Michigan alum, and you know what, we're all proud and all that of being from Michigan, except when the football team loses. And it's great to see that this idea, here it is, growing out of the university here and elsewhere, of course. But we have a great leader doing that. It's really remarkable because it really has, in many ways, transformed some of our thinking in healthcare about how we approach transforming health on a national scale. And the fact that it's part of the Affordable Care Act is truly quite remarkable, and it is having its influence in its own way, affecting many, many people in this country. And I don't think, you think of a policy, there are not a lot of policies that can have such a huge impact on people in this country as this has. So now thinking about this, and it struck me, you know, this what's really amazing is this VBID seems to be sort of Star Trekian. Now, being an old guy, I remember watching that faithfully every day, and so you remember Star Trek, you go where virtually no other program has gone before, and this one too has gone to the bipartisan zone. How weird is that? Even, you know, in these kind of times, I mean, they don't agree on anything, but this is one thing where it seems like everybody wants to support the concept, which is really a sweet spot, and I hope we can find more of that. It's really interesting to see this bipartisan, bicameral effort to bring VBID for better care, you know, into our Congress and have support from both sides. So why is that? It's true. Maybe it's because at its core, the VBID benefits people. It benefits people who really don't have a voice in the healthcare conversation. It makes a difference for them. It makes it easier for patients to have access to things that make them healthier. And that's what it's all about. At Emory, I said, our core purpose is to make people healthy. Now, the public health colleagues said, no, we have to keep them healthy. Of course, I reminded them that since life is a fatal condition, we're actually making them healthy. But we won't get into that sort of which side of the egg do you crack first. But it's a powerful, powerful message. But and so I really sort of like this approach a lot. And clearly, you know, there's a lot of tuning of this. There's a lot more thinking to do about it, as is evident by the panels here today and what will be discussed. And I hope that you can take these ideas and push them even further. So I kind of think of healthcare, you know, people talk about the R's of healthcare. I have 6 R's. Let's see if I can remember them. Now I'm ad-libbing, so it's dangerous. But it's the right care in the right place for the right person by the right health professional, which could be a community worker, at the right time for the right price. Now, it's a little outrageous when you have a physician saying that the right health professional. And I know I watch those wars. They're, to me, the stupidest wars I watch. But anyhow, it may be because it's about money, and maybe with value-based insurance design, you could actually change that paradigm where there'd be much more enthusiasm for the right health professional participating, who might, by the way, be your grandmother with a stick. Think about it. Got to think about that. Okay, a few people are thinking about it. So what else do I want to say? Probably have said enough, I guess. I could go on. I had a football analogy, but I think I'll let that go. It's been, he's right, it's been a little difficult. You come back and, you know, you're looking forward to the football season again after being at Emory, where, for those of you who know, Emory has never lost a football game in its history, which is, of course, they've never played a football game in their history either, but hopefully we'll do better there. But I really hope that during this day that you can use your imagination. The questions will drive the thinking and the imagination to really kind of take this concept forward, and how do you refine it, and how do we, working together, really improve the health of this country and of other countries as well through innovative thinking, innovative ideas that promote health and healing in a positive way. So I want to say thanks. I wish I could stay for this entire session. These are topics I personally really enjoy and have been engaged in over the years. Unfortunately, I have to go to the President's weekly cabinet meeting where, you know, who knows, we might talk for an hour about athletics or something like that, which is really relevant to the Executive Vice President for Medical Affairs duties, so I will have to depart. But let me say, I'm glad to see you here. It's a brilliant group of people. You all have ideas that can make a difference. So let's see action. Let's see ideas. Let's see new solutions. And I look forward to getting a full debrief from Mark after we're done, and of how we're going to move forward in transforming health in this country. So thank you for this opportunity to say welcome. I'm glad you're all here.
high deductible health plans coupled with health savings account. This was a creation of the 2003 Medicare Modernization Act, which actually is also the Medicare Advantage program, which is the subject of the next panel, was also a creation of that same law. So we're taking a 10-year journey back to talk about that law, and that law that created these health savings accounts coupled with high deductible health plans. They're governed by the Department of Treasury and specifically the Internal Revenue Service. The basic gist is that folks can offer a high deductible health plan, and if that, they can enroll in a health savings account if they're also enrolled in a high deductible health plan that meets certain requirements for a minimum deductible and as well as maximum out-of-pocket costs. And those are set in the statute and they're tied to inflation, so they've moved a little bit throughout the years. As part of that legislation, there was also what's called a safe harbor for preventive services, in that if you are offering one of these HSA eligible high deductible health plans, you can offer certain primary preventive services before the deductible is met and not run afoul of other IRS rules. The idea is that if folks have a high deductible health plan, they would be encouraged to maybe shop around for care and sort of get under the hood, if you will, of different healthcare services to see what they would cost before possibly needing those services. So the idea is that most care would be, you would have to meet your deductible before the coverage would kick in at possibly like an 80-20 co-insurance amount. So the thought being that you wouldn't want to penalize folks for enrolling in primary care services or to getting primary care services by applying the deductible before those services are met. So this safe harbor existed. When the Internal Revenue Service wrote the original guidance, it's not even a regulation, but it's actually just a guidance and a bulletin that the Treasury Department issued. They defined prevention as very, very narrowly. It really only encompasses primary preventive services, meaning you can screen for certain diseases, but if the disease is actually present in that individual, you can't cover things used to treat or mitigate the progression of the disease. That would be considered secondary or even tertiary prevention. So moving forward, you have, after 10 years, those regulations were written 10 years ago, or that guidance was written 10 years ago. I think a lot has changed in the last decade as far as what we know about treating or preventing chronic disease and the impact that that has on long-term spending. So the PBID Center, and under Mark's leadership and the rest of the panel will talk about this, has looked at the idea of would there be ways to possibly expand the definition of prevention if you're looking at the existing construct and trying to make a change from a regulatory perspective. Could you expand that definition of prevention that was implemented in the guidance to maybe also include secondary or tertiary preventive services? So with that just very brief introduction, I will turn it over to Roy to talk a little bit more about the research that the West Health Foundation generously funded with the university as well as other universities.
Thank you, Katie. I want to first provide a little bit of a historical perspective because I was actually at the Treasury Department 11 years ago when we first started debating how to define preventive care, and in a Oliver Hardy moment, Mark Fendrick loves to make me Stanley Laurel by basically saying, "A fine mess you've gotten us into this time, Stanley." He loves to blame me for the reason why we're having this debate over preventive care coverage and high deductible health plans. The Treasury Department and the IRS are certainly an interesting place to be debating health policy, and most of us wouldn't bat an eye thinking about its relevance, but to most employers, these are the types of framework issues that they're struggling with every time, and what is a tax-free benefit under an employer-sponsored plan, what does that mean, and how is it constituted? Now that we're in the world of the Affordable Care Act, all of the plans that are being available in the health insurance exchanges, usually in the bronze and silver categories, but also in some of the gold categories as well, we find HSA qualified high deductible health plans. And I'm sure those of you who are paying any attention to sort of trends in the benefit community, high deductible health plans are generally the fastest growing product out there in the market. We don't have the best data yet on the exchange plans, but we do know that the silver category, which is likely going to be a lot of these high deductible health plans, is the most popular category of metal tier plans available in the exchanges. For an HSA policy, however, the original design required no coverage of anything below the deductible except for preventive care. And so there was a lot of discussion from outside groups coming in to meet with us at Treasury and with the IRS, asking us to define preventive care in a variety of ways. And I have to say most people came in with the general notion that pretty much everything's preventive care, right? Everything prevents something. And we quickly realized that this was going to be an issue of where do you sort of draw the line? Somebody's idea of preventive care might be somebody else's idea of treatment or a cure or something like that. So we actually started discussing, are there different ways of defining preventive care? And that's when I first learned about the notion of primary preventive care, secondary preventive care, even tertiary preventive care. And I could see the eyes of my colleagues at Treasury and the IRS, virtually all being tax attorneys, just glazing over and checking out, because they're like, this is health policy. And they were like almost offended that they had to get in there and kind of roll up their sleeves and get their hands dirty in this stuff, because it's not something that they typically do. If you look at how the IRS defines medical care, and even look at the statutory definition, it's very broad. And the only line is drawn at cosmetic. Anything that is cosmetic in nature is not medical care. And pretty much everything else is medical care, especially if a medical professional prescribes a particular service or procedure for you. And they like to be able to hang their hat on the notion of licensure of medical professionals as a way of sort of having a paper trail, if you will, that they can go back in an audit or another situation and determine whether or not that was actually a medical expense. So getting into preventive care, first of all, was not something they were comfortable. And secondly, getting into variations on what is primary preventive care versus secondary preventive care made them even more uncomfortable. We'll get into a discussion a little bit later this morning on, did they draw the line in an appropriate place as it refers to preventive care? Should that line be moved further outwards? I just want to give you a little bit of historical context before we do that. So all of the pharmaceutical companies wanted to make sure that all of their drugs were covered as preventive. All of the medical societies had a very extensive list of procedures that they typically provide, and wanted those to be considered preventive care. And we were presented with a very big challenge on how do you not end up on this huge slippery slope where essentially everything was preventive care. Now the issue is, if everything's preventive care, then you basically don't have a high deductible health plan, because you can drive a Mack truck through that definition and everything can be covered below the deductible, so you really don't have a high deductible health plan at that point. And so that was the reason why this was so important. We decided at the time to end up with a little bit more of a classic primary care definition, primary preventive care definition as a starting place. I don't think we ever expected, though, 10 years later that we would still be there with no changes being made from a regulatory perspective, except really at the margin. So 10 years later, we're now under the Affordable Care Act, and there's a whole new set of dynamics here, many of which seem to be encouraging interest in high deductible health plans. And while not all of the high deductible health plans are necessarily HSA qualified, this whole issue of preventive care is important for the HSA qualified health plans. So the IRS definition is extremely important. About a year ago, I joined West Health, and I run the Public Policy Center in the Washington office of West Health. And we are a nonprofit foundation that is funded by a wealthy couple out in San Diego, Gary and Mary West. And our mission is to look for policies and strategies to lower the cost of health care. And as we were considering various policy ideas and research opportunities to fund, we were presented with an opportunity by Mark and Katie and others to fund some research in this area, because we honestly couldn't find any other research. There have been plenty of research on value-based insurance design, but we never were able to find any of that research as it would be applied to high deductible health plans, and specifically the HSA qualified high deductible health plans. And so we decided to fund their research proposal to look at how to understand the impact of perhaps changing, somewhat liberalizing the definition of preventive care in these high deductible health plans, and what impact that might have on the marketplace. We think this is groundbreaking research, and I'm thankful to Mark, to Steve Parente, Michael Chernew, and all the students that are here that worked on this project, which was delivered to us this May. And I won't steal their thunder, but we definitely thought that this could have a very large impact in the marketplace, but wasn't really something that's being discussed in health policy circles in Washington generally. I think still the concept of value-based insurance design is relatively new, and while it is good that it is starting to gain bipartisan and bicameral traction in Washington, I still think that there's a long way to go in really understanding that. And part of the reason I believe that that's so important is because we've been also paying for a lot of low-value health care for a really long time. And when the IRS definition of medical care includes everything that's low value up to the most highest value care, you really don't get a lot of intellectual support behind these concepts. So I think the battle is still a little bit uphill at trying to convince these people that these are important policy changes from a health policy perspective, and that they could play a small role in actually affecting how that health policy will change. Having said that, I know that there are thousands of employers, insurance carriers, and others who are sort of waiting in the wings looking for some clarification, because they know that some of these things are becoming extremely important in their benefit designs as they're trying to figure out how they're going to deal with things like the Cadillac plan tax and the employer mandate and other requirements under the Affordable Care Act, things that 10 years ago we would have never thought would even be a factor in high deductible health plans, and whether employers would look to them to adopt those plans. But that does seem to be the direction that things are going. So now it's becoming a very important issue, and with the Cadillac plan tax coming in 2018, now is the greatest time really for having this discussion. So I'm pleased to be a part of that. I will stop here, and we'll move on to our next speaker, Paul.
Thank you. Good morning. Thanks for Mark, the opportunity to be here up on this panel, and to listen to these other speakers who I look forward to hearing from. Here we are 10 years after the first HSA was opened, and it's a large market, easily somewhere in the neighborhood of 20 million people enrolled in an HSA-eligible health plan, and millions more, as Roy said, in high-deductible health plans that aren't HSA-eligible and have a lot more flexibility in terms of what's covered and how it's covered outside of the deductible. But we're 20 million people, more or less, out of a privately insured population of 170 million people, more or less. So while it's a lot of people after 10 years, there's still a tremendous amount of room to grow. And I think you're right. We're at the point where we're going to see that growth because employers are desperate to do something to avoid the excise tax in 2018. And you've got the new public marketplaces where the silver plans are attractive because of the premiums, and a lot of the plans in the HSA, in the silver plans, are HSA plans. And also note that we've got about 20 million people in these health plans now. There's close to 12 million accounts now. 12 million people hold an HSA account with assets of $23 billion. So there's a whole nother side to this marketplace that is interesting and relates to the health plan. The whole account, we often look at the account separately from the health plan, which we shouldn't necessarily silo them. At this point, lots of employers offer HSA-eligible health plans. It's expected to grow. But one survey finds that by 2016, 78% of large employers are going to be offering an HSA plan, though not necessarily on a full replacement basis. But there's a tremendous amount of interest among employers in offering it as the only plan option. So in some ways, we're at the point we're at with traditional fee-for-service plans 20 years ago, where employers were starting to phase those out as they moved people to managed care plans. Now they're looking to phase people out of the traditional managed care plans and move them only into HSA plans. And I don't think the surveys out there that come up with numbers, 30%, 40% of employers, depending upon what survey, will be only offering a full replacement plan by 2016 or whatever the date is. I don't know that I necessarily believe the number, because when you survey employers about what they're going to do, those numbers typically don't materialize as fast as they say they're going to move there. Though I think the Cadillac tax may get us there as fast as the surveys are saying. But the point is that the movement is definitely happening. The interest is there, and you're also seeing the growth in the individual marketplace as well. We've been doing some research in this area for a couple of years now. We were able to get claims data from an employer that went to a full replacement HSA in 2007. And keep in mind that 2007 HSAs were around for 3 years. There were very few people in them. Here we are, 20 million. 2007, I think it was less than half that. So this employer replaced all of its plans with an HSA-eligible health plan in 2007. They offered a choice of 2 different deductibles for both individual and family coverage. The individual deductibles at the time were $1,250 or $2,500, and have stayed there since 2007. They haven't raised deductibles, though they give the option to people to move back and forth between the two deductible plans. And 90% took the higher deductible. 90% took the $2,500 deductible, we think because that was free. There was no premium contribution if you picked that, the higher deductible. We got all the claims data going back to 2006 and through 2010. So we're able to follow, depending upon which of our papers you look at, between 10,000 and 18,000 people over this 5-year period. And the only reason why some of the papers are, have a sample as small as 10,000 is because we discovered after the fact that one of the plans that they were using prior to 2007 changed plan codes mid-year. So we thought we lost a couple thousand people in the middle of 2006, when in fact we discovered after the fact that it was the same people, just a different code. And working with this claims data is often messy, and it's trying to get information from the employer about their plans. Often you don't get everything you think they should be telling you up front. But not only did the employer not change deductibles over this 5-year period, they didn't change HSA contributions. So it's an interesting population to be able to study, and we have a comparison group to compare the results against. We looked at things like use of physician office visits, prescription drugs, inpatient services, spending over the 5-year period, medication utilization and adherence, use of generic drugs, and some quality indicators. And I'm just going to give you a sense of some of the findings. The papers are out there. I hope you'll get a chance to read them. You don't have to after this presentation, since you'll know what's in them. But basically, we found that when the HSA was adopted in 2007, outpatient office visits fell. No surprise. Prescription drug use fell. And they remained lower than they were in 2006, the year before the HSA plan was adopted, in all 4 years we looked at after the HSA was adopted. We did find that medication adherence fell for people with hypertension or people using hypertension drugs, drugs for cholesterol and diabetes. They fell in the first year after the HSA was adopted. Once you start digging into populations with diseases, even if you have a sample of 18,000, your sample size falls. So we weren't able to look at the entire 5-year period or the entire 4-year period after the HSA was adopted. We were able to look at 2 years after the HSA was adopted. And while bad news is use of medications to treat these diseases fell in the first year, they look like they're rebounding in year 2. There are some subtle increases for cholesterol meds and diabetes meds, although we didn't find a rebound for hypertension medication use. There was no effect on medication adherence for people with asthma, COPD, or depression. Perhaps one of the most interesting things we found that we can't explain is that emergency department use increased in the 3rd and 4th year after the HSA was adopted. It's a subtle, statistically significant increase in year 3, and then it's clearly a strong increase, very statistically significant in year 4. We went back and tried to tease out, is this due to people with chronic conditions cutting back on their meds and winding up having complications as a result? And I think our sample was just too small to dig into it and explain it, but we certainly found this effect. And we also found that both generic and brand name use fell, but because use of brand name drugs fell more than use of generic drugs, the generic dispensing rate went up. So, which is something that employers look at to measure the productivity of their health plan and their pharmacy benefits, but really should be looking at both brand name and generics relative to each other. I'll note that in the HSA eligible health plan, you can make, as you heard, you can make preventive services free. They don't have to be subject to the deductible. But just because you make something free under one of these plans doesn't mean that people are going to use it. Under this plan, Preventive office visits were not subject to any cost sharing after the HSA was adopted, and cancer screenings were not subject to any cost sharing. Yet we found that in the first year of the HSA, preventive office visits fell, breast cancer screening fell, cervical cancer screening fell, and colorectal cancer screening fell. And some of them rebounded in year 2 and stayed there. And colorectal cancer screening did not rebound at all. It was lower in all 4 years. And remember, this is one employer, adopted in 2007. I've read the plan documents, and I find them confusing. I know what I'm looking for in the plan documents. I'm looking for, where does it say that these services are free? And it took a good 5 reads for me to figure out, this part related to this part, and on some other page, how you get to free. And I think if you're the average plan enrollee not looking for this, you wouldn't necessarily know that it was free. We did try and look at whether or not people stocked up on these services in the year before the HSA was adopted, and we did. We did find this effect in the fourth quarter of 2006, where there was more use of all these services. But we found the same thing in our control group, where there wasn't an HSA adopted. So we don't think there was a stocking up effect as in anticipation of the HSA. And other services fell as well. Medication monitoring fell. There was less LDL testing for people with diabetes, though there was no impact on HbA1c testing for people with diabetes. Couldn't tease out the effects on eye exams for people with diabetes because of some coding issues. And we also found higher use of imaging for back pain and higher use of antibiotics for people with bronchitis after the HSA was adopted, services that are often deemed to be unnecessary, indicative of quality of care. And finally, let me just note that there's no doubt that this one employer saved money, and total spending went down as a result of introducing the HSA. It went down a whopping 25% in the first year. By year 4, it was still 6% lower. Overall spending was still 6% lower than it was in the year before the HSA was adopted. But note that by year 4, lower spending was confined to prescription drug spending only. Everything else came back up. Outpatient service spending came back up. And lower spending was confined to people in the mid-tier. When you divide our sample into 5 quintiles of spending the year before the HSA was adopted, the only people that had sustained savings were people in the middle. So those above the deductible basically hadn't reduced their spending relative to the year before the HSA was adopted by the 4th year of the HSA. So I'll end there, and glad to talk more and answer any questions about this when we get there. Thank you.
Great. So I'm thrilled to be here. So thank you to Mark and the VBID Center, and thank you to Roy and West Health for sponsoring this work. I'm going to talk about the results of the project we did to look at the associated premium ramifications of what we call an enhanced HSA high deductible health plan product. So first, I have to start by saying that Mark said no slides. I thought he was joking. And if I look over my shoulder, I'm looking to see if the next slide is up. It's not a twitch. I apologize. He also said 5 minutes. He said to me 5 minutes, which I just interpreted as him saying, talk faster. Anyhow, so I'm going to do that. I want to start by giving a shout out to Rick McCullough, who's here, who did all of this, the actual programming portion of this work when he was here working at the VBID Center. So our goal was to estimate the cost associated with building this enhanced, I'm going to call it an enhanced HSA, but it's a high deductible health plan with an HSA. It's actually mostly focused on the high deductible part. And in order to do that, we had to identify a set of secondary prevention services that we would then make eligible before the deductible. So we picked things that are typically considered quality measures. I think HEDIS things like medicines for blood pressure, cholesterol, diabetes. We picked the associated diagnostic tests associated with these particular chronic things. It's almost all chronic care stuff. I think in general, for the most part, I know there's arguments about how often people should be tested, but for the most part, the arguments about the goals they should meet. But for the most part, I don't think people are going to argue with the set of services that we picked. But more importantly, I want to make a broader point, and it's possible we'll end up having some Talmudic discussion about what the word prevention means, which I really hope we don't have per the earlier discussion. There is a question about what is conceptually a high deductible plan and how would you measure it, and really it's a plan that has a lot of cost sharing. This is the Center for Value-Based Insurance Design. It's not the Center for Prevention-Based Insurance Design. So maybe there's a PBID somewhere. I don't know. This is VBID. And our goal all along has not been to promote prevention for the sake of prevention. It's been to find things that are high value, some of which happen to be prevention, just to be clear. There's services that would be classified as prevention that might not be high value. And it turns out, I'm an economist, I don't know much about clinical medicine. It turns out there's valuable services that don't fit any definition of prevention, at least not the broadest ones. Anything but the broadest ones. So we're unfortunately hamstrung by the rule that says only things that are prevention can be covered below the deductible. So that forces us to move a bit away from the idea of value towards prevention, and that leads us to these general discussions. And we picked this set of services. So if I had slides, you'd see the services, not that I'm bitter. But in any case, there were four ways in which this would affect spending. One of them is selection and plan choice, which I'm going to defer to Steve, and I'm going to talk about the easier ones. So the first one is obvious. If you take a service that was previously paid for by the individual out of pocket and now is paid for by the plan, there is a shift in spending spending goes up. It turns out, and again, there's a question about the demand response. People use more of a service if they don't have to pay. So we could have a long discussion about the demand response associated with HSAs. There's issues of communication. There's issues of the role that the HSA itself plays in demand. I think some people would like people to think that they're really spending out-of-pocket money and you get the same demand as a regular deductible. Other people think the HSA changes that in various ways. But in any case, we address the overuse with some assumptions. And then what is also clearly true is there's an offset. If more people are taking their medicine for chronic disease, you expect fewer bad things will happen and you're going to save some money on the back end. And we wanted to get some sense of what those magnitudes were. So it turns out, we got data from Truven Health Analytics. They have a market scan database, which is a lot of people in the multi-millions from very large employers. A subset of those folks have high deductible plans. It turns out it's hard to identify who's in a high deductible plan in this type of claims data because there's just noise and what it is. You have people that say, I'm not in a high deductible plan, but it turns out they actually have a high deductible. And people say they are in a high deductible plan, but it turns out the deductible is actually not all that high. So we did a combination of looking at the coding and looking at the actual deductibles that were being paid. In any case, to do the analysis, we had this set of services, and we identified people in high deductible plans. It's going to take me 30 seconds to tell you how we did the shift. We looked at what they're paying out of pocket for these services, and we made it zero, putting the spending then on the plan, and that part went into the per member per month part that the plan was paying now as opposed to the person. To get the elasticity, we did a whole lot of econometric analysis, and we got numbers, all of which were, by all I mean most, were reasonable in the range. But there's a lot of noise when you do this econometric analysis. At the end of the day, we thought it was probably more credible overall to use estimates from the literature from places like randomized trials, and we picked numbers that were not that all that different from most of our empirical estimates of an elasticity around negative 0.2, although understand that that's what you're getting from a trial of cost sharing. The elasticity in a high deductible plan might actually be different. In fact, it might be lower because people have an HSA, they don't understand what's going on, different people selected into it. In any case, we used that number. For the offset number, we used the number that the Congressional Budget Office uses, or the assumption that the Congressional Budget Office uses, in part because scoring tends to matter. So if you're going to talk to the Congressional Budget Office, it's actually useful sometimes to use their assumption. They don't have to score regulatory changes, incidentally, but we still thought that was an accepted number. And it turns out the offset numbers don't make that big of a difference. So the basic results, the set of services we picked ended up generating, when you lowered the price, put them below an estimate of about a 5% increase in premium, or somewhere around $20 per member per month. And that was generally the number that we thought would happen. And the actuarial value of the plan became generous by about 2 or 3 extra percentage points. So now, to reprise my theme about how to pick these services, my view is I tend to be on the opinion that plans should have some flexibility in their benefit design, and that the right way to think about high deductible health plans is plans that have relatively low actuarial values. People have to pay a lot, and within that actuarial value constraint, I'd like to see a lot of flexibility to make sure that the high value things are covered and the low value things are not covered, as opposed to these other sort of semantic rules like, well, prevention's favored, and once you hit your cap, then you have to pay a lot. So I can see, for example, a reference pricing notion where you'd want that in a high deductible plan that's hard to fit in. So I would prefer a model and where you try and find high deductible and HSA eligible plans where you're saying that the actuarial value is at a certain threshold, and give discretion as to how you set benefit design underneath that, because you would want within any of these plans to use the cost sharing in a way that drive people towards the things that are high value and away from the things that are low value. I realize that there's semantic arguments about the word value as well, which is why I'll try and be quicker. But the key point in our analysis is, if you do what I think is the path of least resistance, which is you pick services which on whole other places people are getting rewarded for. No one's going to argue about chronic care management. There's bills about improving chronic care management. There's people that devote their life to improving quality, and many of the quality measures are all about chronic care management. If you take those services, or a set of what I call, consensus type services, and you look at how much is spent on them, if you lower the co-pays for them, if you put what I think is a relatively aggressive elasticity assumption on them, given the way that this is set up, you end up with a premium bump of somewhere around 5% in the plan. And if I had a slide, I would put up all the other results, but I don't. So again, not that I'm bitter. Half of that is shift, about half of that is utilization. The offset assumption is really small. You save less than 1% of premium is on the offset. And I guess the last thing I'll say about that is, and it's really important, I'm a big believer in value and a big believer in prevention. Unless you really target populations and really target services much narrower than we did, prevention, as good as it is not a money saver. These are high value, not money saving services. So that's why you get the 5% jump in spending. And even if they were saving money, you're even breaking even from a societal perspective, you'd have to save even more than that to offset the shift effect. So don't, again, prevention's good. Don't think of it as a way to save overall huge amounts of money, but you can improve the quality of care that people get and remove financial barriers to high-value services. And the cost of doing that in one of these enhanced high-deductible plans looks to be a premium bump of about 5% relative to what the plan otherwise would be. And I'm going to turn it over to Steve in a second and realize it's still cheaper than, say, a PPO that someone might have been in. And so there's plan selection effects that Steve will talk about. But that's sort of the order of magnitude of what you're adding to medical spend for a high deductible plan that charges people for these medicines and these other services that we know they should receive, versus one that makes those things below the deductible by calling them prevention, even though they don't meet some of the strictest prevention definitions that Roy dreamed up and other tax accountants.
Thanks, Mike.
Okay, so first of all, thank you, Mark, and the Viva Center for inviting me to Michigan. It's been a decade, and I'm actually kind of shocked that I made it, and actually made it past the airport, because Minnesota did win the little brown jug back. And I'm sorry, Mark, Mike, the reason why we don't have slides is I had a slide up of me holding in a football suite the little brown jug, and so that's why we nixed the slides, and sorry about that. Just kidding. So it's only once in 25 years Minnesota actually wins a few games, so it'll pass quickly, and you guys will have it back soon. I'm thrilled to be here to talk about some of the work that I've done with Mark and Mike, and really this issue about, it was sort of bothering me about high deductible health plans for a while. I've been an advocate for these for a bit, and actually just want to start off with a little bit of audience participation here. How many folks are enrolled in a high deductible health plan today? Show of hands. Okay, that's better than when I was here last time. It was 2 hands. And how many folks have a non-zero balance in your HSA? That's pretty good too. Okay. So that's about roughly, maybe about, rough calculate, 8 to 10%, if I were to guess, in terms of how many folks are enrolled. Most of what my work in this process was to do is to figure out at the margin how many more people might enroll in both the employer market and the individual market if one of these enhanced high deductible health plans happen to be put on offer. And so let me tell you about the primary way that I go about doing this. A lot of my research over the last 10 to 15 years is focused on consumer-driven health plans and health plan design. One of the tracks of that research has been to create a microsimulation model using employer data initially and then some of the individual insurance data to individual market data to sort of project out what different policy designs would be. And so this is, when you actually do this for a while, you can't just sort of say, hey, it's a microsimulation, because that's boring. You have to name it. So we named it ARCOLA, which I think I always have to look at this as Adjusted Risk Calculator of Legislative Alternatives. It's also the name of the street that I live on. So actually, no one really knew that. There's actually, I think when I was actually at a conference recently and someone was asking me for my home address for getting something, and I said what lane it was on, there were at least 3 people in line that were suddenly surprised and upset that I was that silly about it. But it was actually Roger Feldman's idea, my colleague, that named it that originally. So what does this do? We basically simulate out the entire U.S. population under the age of 65, and more recently we've actually have Medicaid designs in there as well. We published this work in Health Affairs and a few other places just for validation's sake. For this work, what we did is we took what Mike was talking about, this enhanced high deductible health plan, and added it as a plan choice, both in the individual insurance market and in the employer-sponsored market. So it's not the easiest thing to kind of whole cloth throw in a brand new plan design and see what's actually going to happen. There's some folks who do actuarial studies, and you understand that there's a bit of alchemy that's involved in this. And I'm not an actuary myself. My best man for my wedding was an actuary, and that maybe that counts. But and he was from Massachusetts. But what we ended up doing was essentially saying, what are the key features that might attract somebody into this? We know we have a premium that went up, so that will pretty much make it less attractive compared to the average high deductible health plan that might be on offer. The thing that's actually kind of key and what would make someone more likely to choose a plan is if they have a chronic condition, if they know that there are certain medications that they have access to or certain procedures that are free, that might be more of a draw for them. And so one of the things that we had in our simulation model was the presence of chronic conditions. So what we sort of tweaked this to say, what if this plan design essentially allowed someone to choose this enhanced high deductible health plan, but instead of having the normal sort of a prediction term for that design, we actually gave it a prediction design that's about halfway to what a PPO design would be, given that you have a chronic condition. That was our way of kind of signaling to somebody who might be, looking at this as more of an opportunity to consider taking it. It's a little bit of inside baseball, a little bit of alchemy, but that's sort of our starting point. We had different sensitivity tests about what was going on. So premiums going up, we're signaling to a chronically ill person that there's potentially opportunities there. Now, why does that matter? For secondary prevention, as Mike said, diabetes drugs, potentially for people with depression, drugs that go along with that as well, asthma. This is essentially a benefit design that you now have some, at least for generic coverage potentially, coverage that you didn't have previously. So we put this together, we simulate out usually 10-year runs, because we try to have these things so they're comparable to what a CBO estimate would be. Potentially this could be a legislative proposal. And we find that in the individual market, we might have, by the time we get to 2023, 4 million fewer uninsured than what the CBO currently projects the uninsured rate to be, which is about 32 million people uninsured by 2023. We would say it's less than that, by 4. And there's some sensitivity tests around that. Now, the employer-sponsored market, which is really where a lot of the conversation is here, the action can be a lot higher, because so far there's been a lot of movement toward the high deductible health plan market growing in that space. If you look at the current Kaiser survey of the employer-sponsored market, it's now a bigger share of the market in terms of what people are choosing than HMOs. So that's usually kind of startling when you put it in that comparison point. And what we suggest that number, over a period of time, could grow by another 20 to 30 million if this was offered. And given the current tracks of where this has been, that's not that unreasonable. There's a question of upper limit of where this design would actually fall. But remember, you have a lot of folks that are out there that are chronically ill. They're working. There's an issue about what we define as a vulnerable population. And many times people will say, well, if you're chronically ill, you're vulnerable, and you're in a really sad state of affairs. As someone who does a lot of work with employer-sponsored benefits and sees a lot of claims data, I know from my own employer base at, say, the University of Minnesota, we have a lot of people with chronic conditions that are high-performing people. And so there's probably about 40% of our workforce. And so if you're basically signaling to them that to the extent that there's medications that are available to sort of give them a cheaper premium price point, but essentially enable them to sort of stay high-performing, that could be at the margin, and this is a marginal analysis, a more attractive opportunity for them. So our role here was really just to see whether this thing would really have a chance and play and actually get some attention. Was everybody going to swarm to it? No. But it might provide an opportunity to actually reduce the uninsured and actually make a more robust market in the employer-sponsored market as the pressure for Cadillac designs move ahead. So with that, I'll yield to the panel and into my microphone.
Great. Thank you, Steve. So I'll just make a few points to kind of close out the panel, and then we'll open it up to the audience.
So as Mike alluded to, I think there are really two strategies for moving forward some type of a change. So one would be a regulatory strategy in which folks would work with the administration and specifically the Treasury Department to get that definition that's in the guidance expanded. And unfortunately, as Mike alluded to, you really are confined by the word prevention. And you're trying to create a more encompassing definition of prevention. So that's one route. It does create a problem, though, of how do you define prevention in a way that, as Roy mentioned, that sort of everyone and their mom came in and talked to Treasury and IRS about getting their specific thing or their bright, shiny object included as piece of prevention. So how do you prevent that from happening, but at the same time still ensure that you have a lot of the high-value services that we've heard Mark talk about included? So that's bucket number one, sort of the regulatory route. Bucket number two would be a possible legislative route. And I think, as Mike mentioned, you might have a little bit more flexibility if you go the legislative route to say, you know, we'd called this prevention, that was a decade ago, let's think more about value and not constrain ourselves to the definition of prevention and talk more about high value services, maybe under a certain actuarial value type cap of plus or minus 5% maybe. Or plus or minus 4%, which is the de minimis allowed for the exchange plans now at the different metal levels. So you really have those two strategies. So with that, I mean, I think there are pros and cons for going the regulatory route, and there are pros and cons for going the legislative route. I think some would think maybe the regulatory route might be a little bit easier than the legislative route, given how well Congress works together right now. So Mike, I will put you on the spot just a little bit to maybe talk a little bit more about if you do go the regulatory route and you are confined by that definition of prevention, maybe there's some way that you could start to put a box around it by pertaining to chronic conditions, maybe listing a few top chronic conditions by spending, have some type of an including clause but not limited to, so including diabetes, hypertension, heart disease, but not limited to those diseases, and then maybe follow that up with some type of an actuarial value constraint. Will you just talk a little bit about that?
I do agree that you're going to need sort of a belt and suspenders kind of thing, that on one hand you're going to end up with a definition of prevention that is looser than per our meetings that we've had with Treasury and IRS and them. They want some fence, right? And I think that's going to have to be an actuarial value type fence. And then the question is, what words do you put in? So if it was only actuarial value, they're very worried about two things, and I think they're legit worries. So one of them is selection, that the plans start offering a set of services that pull different people in ways that they're manipulating things. And the other is discrimination, so that they're giving services to some folks and not others. I'm actually a little more skeptical of the latter, not that I think it's an unimportant consequence that shouldn't be looked at, but I do think we allow people to be treated differently based on their clinical condition. The whole point of medicine is to treat people clinically different, right? I want the doctor to treat me, not like some other average patient. So you want people to be treated differently, and we give them case managers and a whole bunch of things. So I'm not so worried about it. So the point is, you are going to need some words to address that. I think the part that I'm not very sophisticated at understanding is how one thinks about the flexibility and the enforcement, and I think the actuarial value thing solves that problem in a way that allows you to put in a bunch of words, but because you have this other backdrop, you don't have to argue about them. Even the current model, there have been plans that have pushed the boundaries of what prevention is. Anyway, I'm an economist. I'm not. In any case, and there's a question of how aggressive the IRS or other people would be in calling them on it. So I like the idea of starting with the notion of an actuarial value, putting some words in that are relatively vague, like diseases such as or things including, that you know people could kind of get around, but in the most egregious cases would give you the ability of ex post to stop it, and then let there be some enforcement mechanism. I worry, honestly, about doing that people will focus on the vagueness of those words. So if I personally were picking with no particular legislative sophistication, I would rather put much less on those words and much more on there's going to be a lot of out-of-pocket spending in this plan, but we're going to allow within that constraint it to be defined in as value-enhancing a way as possible and give the plans the flexibility to determine what value-enhancing is with my personal view would be broad discretion. But I do think some language like you described might be needed to make the medicine go down regulatory-wise.
Well, and I think it's important to remember, I mean, there's a reason that enrollment in these plans is increasing and that we're looking at a possible 30% of employers that are looking at a full replacement HSA product. And that is because the premiums are a lot lower. And so if you start offering everything under the sun under the deductible, you've just created a higher premium product. So I think it is important to have some.
Right. And again, but the plans don't want to necessarily have a higher premium product. So the plan's incentive is not to create a Cadillac, a gold-plated, high deductible plan. They want to keep the premium low. It's just you would want them to put their cost sharing on low value things, wherever Marco says. You'd want them to put their premium on their cost sharing on low value things and not on high value things. And the way it's designed now is because of the clumsiness of the language, the cost sharing hits high and low value things basically the same. In fact, if you're a supporter of better chronic care management, and I know you all are, I'm not going to ask for a show of hands, most of the services that chronic care would fit under good chronic care management, people in the high deductible plans, if you were in full replacement, are going to have to pay. That is potentially bad consequences for disparities, bad consequences for health. You'd want the cost sharing on just the low value things.
Right. I think Roy wanted to add.
Well, what I find ironic is that these issues of selection and discrimination even come up because what we're talking about is giving more health care to people with chronic conditions. In most discussions, that would be viewed as a very positive thing, but yet we have to worry about some of these other effects here. So it is a little bit ironic, I think, that how we've already been able to sort of change the tone of the debate just over something simple about, is it preventive care or is it high value care? Which one is more important? Which one should we be pursuing?
Thanks, Roy. Questions from the audience? Yes. I think we have a mic if you just wait. Oh.
I can just, hello? Okay. Pardon? There we go. All right. Hi, my name is Shan Fowler. I'm with a software company called Benefit Focus. Very interesting conversation. Thank you very much. I'm curious, and this question is really for anybody, but I'll try to articulate it because there are so many topics that have been brought up that are very interesting in this space. But there was an article in the New York Times a few days ago about the growing issue of the gap in financial ability for those who are getting their products, individuals who are getting their products on the public marketplaces, largely silver, high deductible health plans, and then really just not understanding what it is that they're doing in a large way. And I think that you can look at those populations, the financially at risk populations, and there are some parallels you can draw with being at risk for chronic conditions and so forth, and being under covered in that preventive space. So I guess the question is, in this space, we're talking about this box of high deductible health plans and actuarial values and so forth. And I guess I'm curious, is it the right box? Is there a different? I mean, are we sort of swimming upstream in the regards that prevention and value and these sort of setting these actuarial values is something that's only ever going to get us so far?
I don't know it might be useful to know what other boxes that you have in mind. I think the challenge that we were facing. Now, I turned my other thing on.
I guess I'll just say really quickly, I don't have another box in mind. I'm just curious if you guys do.
We're still struggling with this box, I think. But Mark has ideas that, now that he's in the IOM, who knows how many will flow out. But I think the issue that arises is that because of the tax advantage portion of the HSA HDHP, you have to limit this backdoor way of giving people just this tax break. And so you need to find a way of doing that. And you can't allow the plans just to become way more generous because of the other aspects of it. And so the question in our parlance is sort of what's the fence? Box is a little, I think what I would argue is we're trying to be as least prescriptive as possible within the general thematic context of value. So you could envision a whole series of, the world of benefit design. Our first conference here when we did this, it was like 10, 40 years ago something, and it was snowing, and benefit design was like version 0.1. Now, the level of sophistication in benefit design, the venture capital and transparency products, issues of tiered networking, limited networks, reference pricing, just a whole slew of the world catching up, which with the economics is you want the cost sharing to go where the excess utilization is. The purpose of the cost sharing is an incentive thing. The benefit design world, independent of us, is an order of magnitude more sophisticated than I think it was 10 years ago. The goal is how to marry those things in ways that get over certain regulatory hurdles, like the HSA rule. So in a reference pricing plan, how would you deal with that if you wanted to build some of these other things in? And I think you could do that conceptually if you got away from some of the words and focused more on aspects of actuarial value. Or I'd love to know some other fence besides that. That's just the one that we came up with. To allow some of these other types of plans not to sit separately from the ideas behind high deductible plans, but instead be integrated. Because I think most folks that are sophisticated in this space are trying to find ways to use cost sharing in a much more sophisticated way and struggling with the communication issues and et cetera. I'm not sure that was a very good answer, but I don't know of any other box to do it, and we're trying to get away from words like prevention, which I think is way too narrow.
So the challenge in doing this is that it's you more likely than not you're going to have to do this through Treasury. This probably won't go through legislation, and even if it does go through legislation, the legislation typically will not look like basically benefit design code. Legislation can't be that prescriptive. Legislative counsel will stop you from doing that type of thing. So it ultimately will probably flow back to Treasury, HHS, or some combination of the two. What Mike's proposing that's sort of attractive by doing sort of an MLR type of piece, or at least an actuarial value, is that it gives a lot of flexibility to the plans to do it. The challenge tactically is Treasury doesn't have the mechanism to essentially audit that. So it's almost like when you think about when we do our individual 1040s, we kind of have a choice. We can take the standardized deduction and go, fine, done. Or we can itemize. There might have to be something that works this same way too, where there's a standard set of buckets that someone says, all right, these are offenses of certain procedures or prevention care that's covered, or you're going to do an actuarial value calculation, you're going to attach an auditor's report to it that said that that's correct. Same thing you'd have to do potentially going in for insurance rating, and you're done. And they're going to have to operate on some sort of trust system. Just thinking about tactically how this would work. Curious about Roy's thoughts about how you could take this to the next level. Otherwise, I'm not sure how you advance this agenda. And Mike's point's correct. The sophistication of the benefit design world now demands this because the data and the IT and the actual projections are getting that much better. So we need to find a way to move to that next step.
Yeah.
I think the question's for Paul. You talked about the outcomes in your study and about adherence rates going down, but employer costs also going down. Anywhere in your study did you assess any changes on providers and provider pricing and issues surrounding variation in shoppable services? So essentially the price went down because you shifted the cost as opposed to the cost going down?
Provider pricing, and I don't think we had rich enough data to do that given the
Yeah, because obviously the
population.
cost would go down if somebody else is paying it for the employer. I wanted to know, did we truly take out any cost? Okay, thanks.
Hi. I'm wondering, as a person who works with corporations to try to implement these HSAs, and there's two big areas that we find ourselves continually frustrated with, and that is when they offer an on-site clinic and they can offer it free to everybody except the HSA folks, and they have to pay the same amount they would in the outside world. And it comes back to this discussion of what's appropriate to cover and what's not. Has there been any discussion about, if you looked at the cost of, for Medicare, of people with certain chronic diseases, diabetes, hypertension, high cholesterol, congestive heart failure, et cetera, and so we actually took a financial approach and said, if we set up pathways of care, so here are the pathways that have been identified by the United States Task Force, NCQA, BTE, what have you, that we can stand on the shoulders of that academic research that's already been done, and then go back and say, for this value, which has been defined in preventing cost for these chronic diseases, we will allow those services to be rendered under an HSA plan by the corporation. So we actually are saying this is going to cost Medicare a fortune. It also is what's costing the corporations a fortune. It's been thought through. Let's allow those things that will decrease those costs, thus the cost to the United States and taxpayers, to be defined as high value. And we back into it that way instead of some academic discussion about what prevention is, and really get, have the rubber meet the road and get all the stakeholder incentives aligned.
Stunningly egocentric, I don't mean it to. Everything ends up one way or another in some academic discussion of something. At least in my world. But the issue there is two things. First of all, most high-value services are not cost savings in when you do all the projections over time, although many people would like them to be. And as a result, you either have to go very narrow with some very selected things. There's some work a colleague of mine, Allison Rosen, did on diabetes services for Medicare. So there are some that might be cost savings. But for the most part, many of the things in the populations we're discussing would not play out, even over a lifetime, as cost savings, although it would be great if they did. And that we could argue that, but I think that is true for a vast majority of these services in most populations. So that's the first point. The second point is, and again, I would defer to people with better sort of legislative sense, is the idea of a solution that gives things to a new task force or expands the charge of an existing task force has become problematic. So the problem with the U.S. Preventive Services Task Force, which is the definer of many of these things, is they are very limited in the set of services they look at. So they pick services that don't meet this broader definition of prevention. They pick services that are for asymptomatic people, for example. So this is all about picking services that are not. Many of the ones that actually would save money would be services that you would give to people that had worse symptoms. In fact, almost by definition, we've done it wrong. If you wanted to pick a set of services that would have a better financial profile and improve health, you would pick services that are given to really sick people and make them better quickly. You would not give a bunch of services to asymptomatic people. It turns out that most of the way the law is written focuses on prevention as services given to asymptomatic people. You don't get as much health benefit, you don't get as much financial you don't get as good a financial profile. Although I should say, just to be clear, I'm all for giving people those services. And that's really what the gist of this debate is. And then the problem is if you wanted to expand it to do exactly what you're saying, you end up with a debate that's sort of like a Picori disaster debate or some other academic discussion, because people, and academics cannot agree on the underlying modeling for services, because it's not just the service, it's who gets the service, it's who delivers the service, it's over what time, what's the alternative. So it gets you back to an academic discussion, and people aren't willing to set up the institution to do that, although I have to say I would not be opposed to that. I would not be opposed to expanding something like the U.S. Preventive Services Task Force to allow them to look at some sets of services that would be more important. But I don't know, and I would refer, that there's a lot of appetite for that. That seems to get played out in public as another role for more bureaucrats or stuff to control things. And very few of those things would save Medicare money in the grand scheme of things.
So speaking of expanding the data, you're looking at cost savings from a healthcare perspective. But for the employer, is anybody looking at the other organizational costs? So let's talk about absenteeism. Let's talk about productivity. And to the point earlier of, okay, there was the 25% savings with the plans early on, but 3 and 4 years, what have you. Where's that data?
So actually, Teresa Gibson was here, and I did some work at using the Truven data on absenteeism. Most times that data is segmented. I don't know what data Paul had. If you had the absentee data. So I agree completely that there's a lot of other aspects of a decision that an employer would take that go beyond the healthcare component of it. That data tends to be segmented. It tends to be hard to get. We did have a portion of that when we did a different study, and we found that it depends on what type of service, but we looked at pain medications, for example. We found what the reviewers seem to think is a strikingly large impact of better pain management on aspects of productivity. There's a lot of other nuances on pain management I won't get into, and that's another talk. But I agree 100% that a full analysis of what employers should do would take into account not just the medical, but also the non-medical aspects of benefit design. I agree.
Paul, the canary in the cave seems to be the ER visits increase. And that has something, I think, to do with primary care. And so what's the relationships that are being developed in HSAs around primary care? Did you have any a study of that looked at that issue? Because the ER visits going up, that seems quite ominous to me.
It's a major concern, and I wish we were able to better document as to why that's happening. And I think everyone in this room has, a gut opinion as to why it's happening, and we're probably most of us in agreement, in our guts, but we weren't able to tease it out. I think there are other things employers can do, this whole issue of productivity and plan design, that they're not. If they were true, while for the most part, most employers haven't moved in this direction of offering an HSA plan because of concerns, whether it's ER visits or productivity or medication adherence. But it certainly seems like they're on the verge of doing that and moving in that direction. But there are things they could do that we're really not talking about. They could contribute more to the HSA account, just to reduce the level of the deductible. If they think that deductible is a huge impediment, yet they're already moving to the high deductible plan, so why would they fully fund the account? They could cover services above the deductible differently than they are. And you see lots of different variation in terms of cost sharing, whether it's co-payments or co-insurance, or co-payments for drugs versus co-insurance for everything else. But they could certainly voluntarily try to cover more preventive services above the deductible or more high-valued services, and they're not doing that either. So, despite all this talk about let's go down this regulatory route or this legislative route, there's a third option, which is just enhancing the benefits somehow. But you're not seeing that because they're looking, for the cost savings, especially now, given the Cadillac tax.
Yeah, hi, Lou Sandy from United Health Group. Through United Healthcare, we have about 6 million people in high deductible health plans. And I just want to make actually a point from your findings that I don't think has been made explicitly. The 5% number you found, that's a huge number. That's a very big number in the private insurance market. And I guess for the very reason that Katie said, that plan sponsors are looking to high deductible health plans because they're looking for a more affordable option compared to what the alternatives might be. So I guess my question, maybe for Mike and probably Katie, but anybody else, is if there was an effort, if we wanted to have a more clinically nuanced high deductible health plan offering along the lines of what you've analyzed, how do we pay for it? How do we make it cost neutral? And I just want to probe Mike particularly around this actuarial value. What are kind of the benefit options that you would suggest people look at to say, here's an enriched benefit, but we can make it cost neutral, meet the price point for a private plan sponsor was looking for that kind of an option?
Right. I agree completely. Let me give you 2 quick answers. So the first answer is, I would rather see a plan that had a somewhat higher deductible in the high deductible world, but then carve things out. So I could easily get you the exact same price point. We just took an existing deductible and then put things under it. But if you give me a little bit of increase in the overall deductible, I can easily get to the same price point because I'm fiddling around with a small share, 5-ish% of services actually. So it's not hard to create an actuarially equivalent higher value, high deductible health plan. So that's my first point. The second point is, and I'll do this by anecdote because it's folksier, when we were thinking about putting in a high deductible health plan at Harvard, and I had the misfortune of chairing the benefits committee, when we actually finally did do it as an option, one of the biggest impediments we had was that we were worried that our employees with chronic conditions would erroneously, I'm not sure I like that word as an economist because we're believe everyone's rational, but anyway, I'll say it here, erroneously choose the high deductible plan and then realize they've gotten into something they didn't really want to get into and they wouldn't manage their chronic care well, and we thought that was problematic. And if we thought, and we did think a little bit about making it full replacement, then we thought we would just be slamming our employees with chronic conditions, which we very much did not want to do. If we had had the opportunity to have a high deductible health plan that looked less onerous on these particular populations, even if it was 5% more expensive than some other high deductible health plan, it still would have been well cheaper than the PPO that we're offering now. And so the issue is the framing. Do you view it as 5% more expensive than the other high deductible plan? And again, we're just arguing to make it an option, not even force it, right? But do you view it as 5% more expensive, or do you view it as, and I can't remember the number from Steve's work, but Steve did the work, do you view it as X% cheaper than the PPO you're offering now? And is the reason you won't go from the PPO to the high deductible plan because of these particular individuals? And so I think that the reason Steve got involved in Arcola, and I'm glad I know where you live, now the reason why that became important is because we understood that the full analysis was not simply an analysis of one high deductible plan versus another, but how it fits in the overall product offering. So I think we A, could make the plan at the same cost by fiddling with other parameters, and B, even if it's more expensive, it actually could be cheaper and more attractive to exactly, you're never going to save money getting a bunch of healthy people into a high deductible plan by and large. You have to deal with the people that have chronic conditions in a whole variety of ways. And so you want to get them into plans that might make them more cost conscious. And doing that by charging them less for the things you know you want them to do seems like a smart way of doing it. But we need companies like United and others to come up with these sort of sophisticated things. And how you frame it is the whole ball of wax.
Joe Thompson, kind of policy entrepreneur of 15 years or so. So academic studies always lag implementation. Implementation always lags policy development. We've got on the IRS site for the Safe Harbor Preventive Care Screening Services. I see what the problem was 10 years ago that we're trying to solve now. Fast forward for me 10 years from today at this conference when 10, 15, 20% of conditions can be genetically profiled. How does this play out in a high-value HSA plan?
I'll take. You're smiling because you know I have no idea. So let me say more broad.
I'll answer it anyway.
I feel obliged, and they gave me the mic. I think there's, broadly speaking, two streams of sort of intellectual thought around transforming the healthcare system. One relates to better benefit design, which we're talking about now. The other relates to payment reform, which you know an enormous amount about, and I won't go into. And I think we have to figure out how they're going to be married. Well, the way I would take this discussion about how it plays out is we have been trying to advocate for a system that is somewhat more flexible. So as we have new sets of services that we think are high value, and we have new payment models that folks are getting paid in broadly, we can have flexibility in how the benefit design matches the payment and that matches the measurement. So I don't know what's going to be high value or not, but I don't want to keep getting into an argument of whether it's prevention or not. And when you do, Joe's actually, in addition to being a policy entrepreneur, he's the Surgeon General and the man behind the initiatives going on in Arkansas, payment reform in a whole variety of ways, which is something I encourage you all to look at. But the point is, if you look at what Arkansas is doing, a lot of which is payment focused, not benefit design focused, there's a question about how to engage consumers and what level of flexibility you want and how you make the benefit design that those people face match the payment goals that you have. And right now, the way the models are set up, that turns out to be hard to do because of some word choices that were made in the past. And I think you could reframe this whole discussion about how to give the flexibility in the benefit design process to have the payment reform and the benefit design and the quality movement and the measurement community all move together to promote value, which everybody's trying to do, as opposed to have them, the way I see them now, is moving in quite separate communities. And even in the benefit design, you have the high deductible people that view deductibles high-low, and then you have reference pricing people and a bunch of other people. And that's not even integrated in the way that Paul said earlier in a bunch of different ways. So I think the flexibility will allow more integration of the many types of initiatives we're moving, and hopefully those will be further along 10 years from now.